Hello, I'm Sarah Hoke, the Rocky Mountain HIDA, Colorado Drug Intelligence Officer. I'm excited to introduce our next presenters, Drs. Carl Hill and Pamela Buckley, who will share with us strategies for selecting and implementing upstream interventions within a system of prevention. Dr. Hill is director of the Prevention Science Program, co-principal investigator of the Blueprints for Healthy Youth Development Registry, and professor of psychology and neuroscience at the University of Colorado Boulder. Dr. Hill's work over the last 30 years has focused on understanding two questions. What are optimal family, peer, school, and community environments that encourage healthy youth and adult development? And how do we work with communities to make this happen? His research has informed the development and testing of interventions to improve youth development and break intergenerational cycles of problem behavior. Dr. Pamela Buckley is a senior research associate in the Institute of Behavioral Science at the University of Colorado Boulder. She is also principal investigator of Blueprints for Healthy Youth Development. Her expertise is in testing social programs designed to prevent antisocial behavior and promote a healthy course of youth development. She has extensive knowledge of the prevention science literature and expertise in the design and implementation of evaluation research projects. On behalf of the Rocky Mountain HIDA, I would like to welcome Drs. Hill and Buckley.
Hello, my name is Carl Hill. Thanks for coming today. I'll be presenting on selecting and implementing upstream interventions within a system of prevention. I really do wish I could be there today. When I was invited, I thought this sounded like a fabulous opportunity. But my wife and I are going to be visiting friends in Venice today, if all goes well, on October 6th. You'll be watching it here through this recorded Zoom instead. I'm a professor of psychology and neuroscience at CU Boulder. And what I'd like to walk through today are three basic parts. I'd like to go through basic prevention principles as they're related to community-based prevention, what I think we've learned over the last 30 years in upstream prevention, some examples of community mobilization and community-based prevention, and then I have a few slides at the end to just as thought points or discussion points. Before doing that, I'll give you a little bit about my own background and how I came to this work, keeping in mind the time that we have here for today's session. So I mentioned that I'm the director of the Prevention Science Program at CU Boulder. That program has about 75 people working across 10 different projects, mostly in translating what we know about prevention science into community-based prevention planning. I'm also the director of a prevention registry called Blueprints that, along with Pam Buckley, is providing a sort of a consumer report of what works for prevention planning. So I'll talk about that in a few minutes as well. But first, I'll give you some of my own background. This is me in 1983 with hair and not gray. And I started out at the University of New Mexico working in treatment, as many of you probably are. It was good work. We were working with people who had problems with addiction and violence and depression, often all of these together. And I really did appreciate the work. The one thing that I became frustrated by was that I felt that no matter how good a job I did, I wasn't stopping the pipeline of people through my door. That there would always be new people coming in every day. And I began thinking, isn't there some way that we can work upstream and work on youth development and problem prevention so that we wouldn't even need to do treatment in the end, so that people wouldn't get involved and wouldn't get addicted. that took me, I got my degree in life course social development, my doctorate in Boston. And then I worked for 23 years at a place called the Social Development Research Group in Seattle, Washington, with Dave Hawkins, who is one of the founders of Prevention, and Rick Catalano and Kevin Haggerty. I really liked the work that they were doing in problem prevention and health promotion. It met with the direction I thought we needed to go in public health, because they took this sort of ecological view of understanding child development, that children develop within a context of who they hang out with, how well their family is functioning, how well their school is functioning, as well as community norms and media exposures. So they took this broader view of development, which made sense to me. When you think about this girl's addiction, this young girl's addiction, you realize that her addiction is a function of all of these things somehow, from genetics up to her psychological system, to what her neighborhood is like, up to national policy and community laws and norms. All of these things contribute, and all of these things have to be part of the solution. So during that time, for 23 years, I ran what's called a longitudinal study, a long-term study that followed 808 children from elementary school into midlife. So we started with 808 elementary school kids, and down on the bottom, you can see the ages at which we interviewed them. The most recent interview I ran was when they were 39, but its study's still ongoing. And as we interviewed them, we held on to 90% of the sample through adulthood. And we asked them not only about their drug use and other behavior, but also about what's going on in their family and their peer group, in their school and work environments, and in their neighborhoods. I took this job 5 years ago at CU Boulder as director of the Prevention Science Program. And I want to mention sort of basic prevention principles that I think that we learned over the last 30 years. And the reason why I say 30 years, let's take a look at the field itself of prevention science. Prevention science is a relatively new field. When you look back over the last 2,400 years, biology, physics, astronomy, geology, medicine were established 2,400 years ago. So as sciences, they've had a long time to develop and figure things out. Prevention science started probably most strongly around 1992, 1994. So we've really only been around as a discipline for about 30 years. So we've learned a lot, but we still have a lot to discover. Let me walk through what I think we've learned in the last 30 years. When you see someone in your world who has drug and alcohol problems in adulthood, one of the questions that I had when I first started out was, where did this come from? What are the root causes of his or her addiction and other problems that they were presenting? Well, we had this longitudinal study that we ran so that we could actually look at our data that reached all the way back to 1980 and go back in time and see, when you actually do go back in time, people start out pretty much the same. At some point, nobody's addicted. And then over time, there are different things that happen that push them off track and get them involved in drugs and alcohol and other problems. When I first started in this field back in the 90s, one of our questions was, well, what are the one or two big root causes that we could focus on in order to reduce addiction? And what we found was, well, there were things in the family that were getting kids off track. For example, parents, a poorly managed family, parents' own drug use, harsh discipline practices were all predictive of later risk behavior. But it wasn't just in the family. Also, we found things in the school environment and with their peer environment and in their own attitudes and in their neighborhoods. So one of the things that we found, we thought it could be just one or two things, but the root causes of positive and problematic development reached across every domain. Everything mattered. In fact, many of you in the audience are probably familiar with risk and protective factors for problem behavior. And not just our study, but multiple longitudinal studies have identified a wide range of factors consistently that put kids at risk for addiction or protect them against risk or promote positive behaviors, and these being called protective factors. So that's one of the things that we've learned over the last 30 years is really what are the risk and protective factors that get kids off track as they're developing. And in fact, not only do these risk and protective factors predict alcohol, tobacco, cannabis use, they've also been shown to be predictive of opioid use. So the same set of risk and protective factors that are meaningful for these drugs still apply to opioid use. And interestingly, they actually predict a wide range of developmental outcomes. These same risk and protective factors predict developing violence, suicide ideation and behavior, educational attainment, and other outcomes. So one of the benefits of that is that if you address the root causes, you'll have benefits across a wide range of outcomes, not just addiction. Yes, you'll reduce the onset of addiction in your community, but you will also have the added benefit of improving these other outcomes. Anti-drug education campaigns are really important, but by themselves are not sufficient. So that you can see that one of the contributing factors to child development are media messages around drug use. But these campaigns need to be part of a comprehensive strategy that addresses the root causes across multiple domains, as the ones that we've been talking about here. So with that, media campaigns alone are important, but not enough. Another question that we had in doing this work was, which of the risks are the strongest ones? If we could just focus on the strongest ones, that would make our job easier. One of the things that we found is no one factor rises above the rest. They all have about the same level of impact on the outcome that you're interested in. So they're all important, but they add up. So that what we did, for example, in our study is when I go back to the data and look in adolescence, and I gave every kid a score as to how many domains were they in the worst 25% during adolescence. So they were in the worst family, the worst school, the worst in the peer group, and the worst neighborhoods. So I gave all of our kids a score. That means that any child get a score in adolescence from 0 to 4. And then I looked at their addiction in adulthood, substance use disorder diagnosis in adulthood. So along the bottom, you can see this is how much risk that they experienced cumulatively, and then probability of addiction over here. And what you see is indeed, these risks pile up so that those kids who are in the worst quartile in every domain, 56% of them develop substance use disorder in adulthood. This leads many people to ask, maybe we should just focus on those high-risk kids, those used at high risk. Why waste prevention dollars on kids who are low risk in the first place? Well, let's think about that for a minute. This is called universal intervention, where you're delivering your intervention broadly to everyone in the population. In the intervention spectrum, we talk about all the different ways in which you can provide an intervention for people. At the beginning is health promotion, presented broadly, prevention programs, moving into treatment, and treatment maintenance. There are all these different ways in which one can intervene. For example, later one might be preventing overdose occurrence or relapse, but that's much later than what I'm talking about. What I'm talking about today are the upstream efforts at preventing kids from getting involved in drugs in the first place. Those interventions that are broadly applied are universal or health promotion. You can also select out those kids who are at high risk and give only those kids an intervention, or you can give those kids who are already showing problem behavior the intervention. So what I just talked about was the high-risk kids are selective, and the broad universal strategies are for everybody. So let's look at that. And this is, I would say, so everything I say here is my reading of the science. But my reading of the science is that a prevention program that focuses only on youth at high risk will fail to move the needle on addiction at the community level. And here's why. Is you say, well, when we should only focus on those high-risk kids with a selective intervention, those kids only comprise about 5% of the population. Yes, they're at high risk, but they're not as prevalent as the low-risk kids. And in fact, they only account for 10%, 9% of addiction in adulthood. The other 70% of the people who presented substance use disorder in adulthood came from kids who were at low to moderate risk. So if we had only focused on the high-risk kids, we would have missed 70% of the people who would later go on to become addicted. This is called the prevention paradox, which means a large number of people exposed to small risk might generate more cases than a small number of people exposed to high risk. So for me, my own recommendation based on the current science is you have to do both. I recommend that communities do planning for a selective intervention for youth at high risk. It's the right thing to do. They're at high risk to developing addiction. It's the ethical thing to do. But you're not going to move the needle if you stop there. That you need to embed that within a universal prevention strategy in order to move the population needle. So I recommend to communities that they try to have both components in their planning. One way to think about it, we'll see whether this works or not, is if you have popcorn and you're trying to figure out which one is going to go next. And you're sitting there and you're thinking, oh, that one's going to go next. Oh, no, it didn't. That was the wrong one. We turn out to be really poor at trying to decide which one's going to go next in popcorn, as in kids. So selective interventions or indicated interventions are trying to identify those individuals who are actually going to develop addiction, but they don't always. Instead, what we can do is turn down the heat, which makes it less likely that anybody's going to go next. So universal interventions are trying to bring down the overall risk level in a community to improve the risk of everyone in the community. Another way of thinking about it is called shifting the curve, which is a really neat public health idea, is that when you think about the distribution of problems among kids, at one end, you've got kids who are involved in addiction and violence and are doing antisocial behaviors. And at the other end, you have highly pro-social kids who are doing well in education, they're constructively engaged, they have good mental health. And then there's the average kid in the middle. Well, when you look at the overall population, if I can shift the population just a little bit, what you saw there was that small shifts in the population results in big changes in the tail, so that the number of antisocial behaviors in the extreme are reduced rapidly and the pro-social behaviors increase rapidly. So this is called shifting the curve and makes the argument for small changes in population-wide behavior. So what have we learned in the last 30 years? I was running these backs by some of my colleagues, and they said, yeah, I would agree with that. So one, the causes of disordered and positive development reach across all areas of influence: family, school, peer, community, and individual. Not just families, not just schools, they all contribute. These same factors affect a wide range of outcomes. Each of these causes has about the same impact. However, they have a large cumulative impact. They add up. Like Pink Floyd said, another brick in the wall. All of these things add up to create a kid who is at highest risk. For a number of reasons that I just walked through, a good community prevention strategy embeds a selective intervention for kids at high risk within a universal strategy. And now I'm shifting over to talk about community interventions. Another thing that we've learned is that getting communities to select and implement what works, tested effective interventions, takes planning, but we do have successes and ways and guidance for communities on how to do that. So let me move into community-based prevention. I need to check my time here, sorry. Oh, okay, I think we're good. I like to think about the olive of prevention. Unfortunately, most of what we are implementing in communities to prevent addiction has little or no evidence of effectiveness. So when you think about an olive, that's this part. There's the stuff that we do in communities, and we don't know if it works or not. And that's the major part of prevention efforts. The little red part here is what we know works. There are interventions that we know have proven effectiveness. But then this part is what we actually do that we know works. So we don't implement as many interventions that we know work that we believe should. And then there are the things that we know doesn't work that we are also implementing. And we know that there are things that don't work, but we're doing them anyway in our communities. So let me walk through two quick community-based prevention strategies. One are called population strategies, and the other I think of as community mobilization. And population strategies, I'll mention briefly here, are trying to change some feature of the community as a whole, like policy changes, smoking, vaping, and cannabis laws, improving access to healthcare, improved recreational spaces, community-wide health initiatives. So you're changing the features of the community as a whole. As a quick example, you probably know this from your own neighborhood. You walk into the convenience store and they have the power wall, so that right behind the cashier, you have all of the tobacco you might want, and right next to you you've got your Red Ball and other bottles of alcohol. So this is called the power wall. It's really effective marketing for these industries. But what they've done is develop point of sale display bands so that the power wall is behind a door like here. And what this study did, for example, is they looked at the impact of doing point of sale display bans in convenience stores in 20 different countries, and found that they were able to reduce smoking in adulthood from 7 to 9%, 6% for men and 9% for women. For example, in Scotland, this is their smoking in Scotland, and that's the point where they implemented their point of sale display ban. So this is a nice example of a community-wide strategy. Within my lifetime, I remember when all of these things were implemented. Smoking on airplanes, advertising, taxation. And in fact, when you look at smoking in America over the last 100 years, there was a huge increase during the war, and then gradually we've been bringing it back down through these strategies. So population strategies can be effective, but they're not sufficient to get a handle on addiction. You need more. And that's why the next part of this is community mobilization. And in community mobilization, you're involving members of the community in the planning, development, implementation, and evaluation of programs and strategies at these other levels of influence. These other interventions could be at the family level or the school or community level. So you're not mandating laws across a whole community, you're mobilizing communities to work together to implement what works. I'm going to walk through, there are several different mobilization strategies that are available. I'm going to walk through one example that I'm most familiar with called Communities That Care. CTC is not an intervention. It is a strategy that guides communities through the steps of science-based prevention. I think I have time here. I do. I have a short 5-minute background from folks who are actually implementing CTC in Camden, Maine, and in Montbello, Denver.
So many communities want so deeply to help their young people, but they don't know how to go about it. CTC shows you how to do it, gives you great tools so that you can do it efficiently and effectively.
I think the Communities Care model can really help our community bring in a number, if you will, resources together to have a collective impact in reducing the crime.
Montbello is a neighborhood in Denver's far northeast area. Montbello has historically been underserved. Communities That Care was chosen because, well, for many reasons, the evidence-based nature behind it, but also there is a requirement for significant community involvement.
Communities That Care is a process for organizing all the stakeholders in the community who care about young people around a common science-based framework to promote the healthy development of young people by reducing known risk factors in the community, enhancing protective factors in the community, and using evidence-based programs and policies to achieve better outcomes for young people.
When I saw CTC and the Research Foundation and the strong background that it had, I really felt that this had a good chance of making a difference here in our community.
In a large community trial of Communities that Care, we've seen big reductions in drug use and criminal behavior of young people. For example, by the end of the 8th grade, 33% reduction in tobacco use, a third reduction in alcohol use, and 25% reduction in delinquency.
Communities That Care is not a program, it's a process. It's a way to bring all the stakeholders in the community together to make joint decisions based on their own data about what's going to be important for the youth in their community.
So when you look around my community, you may be surprised that we have any problems at all. People are surprised to hear that we actually have pretty high rates of substance abuse, youth suicide, marijuana use in particular. But we found when we collected the data, we do indeed have much higher rates than we would expect of those particular problem behaviors.
The reason I work for CTC is that it's a way to get ahead of the curve. Instead of reacting to problems in kids after they happen and always being on this cycle of reaction, it's a way for us to move upstream and get ahead of the problem so that we can do things to strengthen communities and strengthen families, strengthen school systems, so that we all do a better job raising our children and keeping them out of trouble in the first place.
Communities That Care helps communities choose the right programs and policies for their needs based on surveys of young people and based on data from the community. They then can choose evidence-based programs from a menu that have been shown to be effective in addressing their unique community needs.
Communities That Care really seeks to promote well-being. And one of the things I love about Communities That Care is it provides a strategy for doing that called the Social Development Strategy. It says if you provide young people meaningful opportunities to be involved, and you teach them the skills to be successfully involved, recognize them for their involvements, they develop a stronger bond to that community. When you have the standards and beliefs in place to promote healthy development, they're more likely to follow those standards.
An exciting finding from the Communities That Care randomized trial is that communities using Communities That Care end up strengthening protection across the board. Communities That Care is a good investment for communities. It produces $5.30 in benefits to communities for every dollar spent. Because Communities That Care has been shown to prevent crime before it happens, to prevent smoking before it happens, it reduces the costs associated with those problems.
I think the best reason to use a Communities That Care system is because you know it'll work. The reason you know it works is because there's science behind it. They've done their research. They found out that if you do X, Y, and Z, you get A, B, and C.
Having been involved for 10 years, I've seen that change come, but it doesn't come quickly. And it comes with much effort, and it comes continuing to maintain and continuing to do over and over again. But the fact is, we're seeing results.
Welcome back. It's so strange, I have to say, for those of you out there, it's so strange for me to be talking and not seeing your faces and getting feedback, but here I am, old dog, new tricks. So what's interesting about CTC is that, first, I have no profit, and neither do the people who you just saw, and there's no profit motive. This is was originally developed and given to SAMHSA, and now it's being run in this nonprofit called CTC. So let me walk through what they were just talking about in some detail on what the people in the video were just talking about. CTC starts with community, so that it starts with having the people in your neighborhood. Think about the people in your community, your mayor, superintendent of schools, the head of children's services, your police chief, in the juvenile court. You need to have, it's helpful to have these people on board and believing in prevention and believing in the effort. We also try to elicit the support of key leaders in the community who shape opinion in your area. Out of that, you develop a board, a CTC board, who's going to be doing the decision making and planning. It's important to have the community members on board at least in terms of being open and receptive about prevention and understanding what prevention means, so that sometimes you have to do what's called a readiness campaign to have people understand what is prevention and that this is something that's coming to their community. And there's also a component of youth involvement in all of this planning process as well. The only paid position in all of this is the single person, a CTC community coordinator who coordinates the meetings and activities throughout the next 5 phases I'm going to show you. So it starts with forming work groups out of these members. What do the work groups do? Well, in the first phase, you find out, is the community ready? Is there an understanding about prevention in this community? Who are the key leaders? Who are the key stakeholders in the community? You form a coalition, and that coalition learns what you're doing today. Some of you learning about prevention science, writing a vision statement, developing a timeline for your community. And then you do a youth survey to find out what's going on in your community, because every community is different. So for example, this is a profile that you might get. Down along the bottom are the risk and protective factors that I mentioned earlier, like community disorganization, poor family management, etc. And then through the youth survey, you get an assessment of what your community is elevated on. So this community was especially elevated on poor family management, parent attitudes towards drug use, and child attitudes towards drug use. So what we would recommend is when they're looking to pick a prevention program or more, that those programs should address those factors that they are elevated on. And then they identify their existing resources that they can bring to bear in the planning process. And using the risk profile, they select interventions with good evidence behind them. This is a difficult step. How do community members know what works or not? It's not their job. They're moms and dads and police chiefs and everybody else. It's hard to know what works or not. A lot of things sound good. Well, that's where Blueprints comes in, is that the registry of tested effective programs that Pam and I direct does the work for communities. So we provide communities with a guide to what works in terms of prevention planning. Every intervention on Blueprints gives communities a broad amount of information to help them make decisions to say, is this a good choice for us? Can we afford it? Is it targeting the right risk factors? I travel a lot and talk to different communities, and a lot of communities are implementing things that have weak evidence. They're still very popular. DARE is very popular. They've done a number of evaluations, but at this point, we haven't seen the evidence strong enough in DARE for us on Blueprints to be able to certify it. They're still working on it. Boot camps is another example. Military style boot camps, very popular. And some evaluations have shown it to have no effect on crime or drug use, and others have shown it to increase problem behavior. So there are a number of programs that have little or weak evidence, but are being broadly implemented. As you can look over this, scared straight strategies, moralistic appeals, zero tolerance approaches. All of these things have been shown. There's a book by Buddy Howell down there on what works and doesn't work. All the slides will be available as a PDF after the conference that will have all this. So my overall message is that communities have to work together to implement things that have been proven to work. Well, like what? What are some examples of things that could? For example, looking across the life course, there is an intervention that has our highest rating on Blueprints. It's a model program called Nurse-Family Partnership that is for first-time low-income moms. And it pairs them with a nurse from the prenatal period through 2 years of age. It's therefore a selective intervention. It's for high-risk kids. But it's been shown to have effects on those kids all the way into adulthood. So community could choose to support nurse-family partnership for the young mom parents, then shift over to Parent Corps, which is another certified model program, preschool, universal for all the parents in the community, and does parent training for parents of preschool kids. You could implement Botvin's life skill training in the middle schools, which is teacher and child training, again, universal for all teachers and children in middle school. And then even as they move into young adulthood, there are interventions like the Cannabis E-Checkup to Go, which is a early adult universal promising program on Blueprint. So communities could develop a package of interventions that address different people in the community who are at different points of their child's development. On Blueprints, when I go to, Blueprints is has a menu-driven search feature where you just click on what you're interested, what prevention strategies you're interested in. And then in this case, I clicked on illicit drugs, and it showed 24 programs that were listed on Blueprints, 8 of which had the strongest evidence, and 16 of which had strong evidence, and we listed as promising. So there are 24 programs certified on Blueprints as showing effects on illicit drugs. So communities select effective policies and programs based on the evidence, and then they implement it, and then they evaluate it and see, is it making a difference in their community? This process that I just walked you through is in successful operation in over 130 communities in the United States right now. So if your community isn't doing this right now, you have lots of other examples of communities that are doing it. Also, in dozens of communities around the world, in countries around the world. I'm heading out on Sunday for the European Society for Prevention Research to talk about these very same things. So that was my talk overview, and now I'm shifting gears. Oh, I think I'm good. To some discussion points. So we have effective interventions, and we have registries that guide people towards effective interventions. Why aren't they being used? Well, you remember Kevin Costner in Field of Dreams. The tag phrase was, if you build it, they will come. Well, we built these interventions and we built the registry, but the answer is they're not coming. Some are, but it's not being implemented as broadly as it needs to be to make a difference in our community. And people say, well, prevention doesn't work. Well, it actually does. And we have evidence, as Dave Hawkins was talking about in that short video, of community-wide effectiveness. Or they'll say they already have one. I talk to communities and they say, oh, we already have a bullying program or a drug prevention program. And I say, well, what are you doing? And they tell me, and I say, well, yeah, but there's no evidence that that works. So it's hard for people to give up what they're already doing. They'll get lost trying to do it. They get started in the planning process, and then the things sort of fall apart and they give up. That's why CTC is helpful, because it gives you these sort of steps to follow through and all the materials to do it. Or they'll say that it's just not feasible. You can't do it. It's impossible. Or they'll say it's too expensive. I hear this a lot as well when I talk to legislators or other community members. Oh, we just can't afford prevention. It's too expensive. And when I think about that, when you look at, for example, this is from the National Drug Control budget. When you look at what we're spending in terms of dollars, U.S. drug control spending, 40% of our drug control dollars go to treatment, 35% goes to law enforcement, 14% goes to interdiction efforts at the border, 6% goes internationally, and 5% goes to prevention. And currently, we're giving more money to other countries to control our drug problem than we're spending on prevention. Another thing to think about in terms of the overall U.S. budget, our discretionary spending, there's mandatory spending, which is Social Security, but looking at, and other costs, when you look at our discretionary spending, over half of that goes to the military. And then the rest of it gets divided up across all the very different things that we talk about in terms of where do our taxes go. So when people ask, we can't afford prevention, my own 2 cents is that in accumulated wealth, we are the richest country on earth. We should prioritize creating healthy places for kids to grow up and live. Healthy families, healthy schools, healthy neighborhoods needs to be a priority, not just in talk, but in spending. Most often, I think that people just don't know that effective prevention exists. It's, as I said, a relatively new field. My current challenge is just getting the word out. And I'll talk to whomever will listen at the local, state, national, international, through publications, talking to the press and on social media about these very same things. That no, we do have the means at our disposal to make a difference in kids' lives. When you think about it, after the Chicago fire, 17,000 buildings were destroyed. And then the Great San Francisco fire, 30,000 buildings were destroyed. We created a fire prevention infrastructure where we improved by mandate all of these things: structural design, material construction, fire protection systems. We now have a fire prevention infrastructure that has greatly reduced the chances of these massive fires. Now you look in America and we have high school mass school shootings and the opioid epidemic, and including opioids. 400,000 Americans die every year from tobacco. My mom, I sat by her bedside as she died from tobacco. So in America, our house is on fire. What we need is a prevention infrastructure similar to our fire infrastructure. We need to build supportive legislation with legislators who understand prevention and build it into law at the state and federal level. We need dedicated, stable revenue for prevention. We need a trained workforce of people who understand what prevention is and how to guide communities through those steps. We need registries of what works. Like Blueprints, we're not the only registry, there are others. We need a prevention-aware public so that they understand that this is possible. And we need toolkits like CTC to help guide them through the steps. We need interagency collaboration. This is really very frustrating for me because I talk to different agencies at the state and federal level, and they're not talking to one another as much as they should, even though the root causes of education and violence and addiction are the same root causes and therefore consistent solutions. They don't coordinate as much as they would be good. And we need to develop community coalitions to be able to make all of this happen at a local level. So this is part of my passion, is to help develop a prevention infrastructure like we did a fire prevention infrastructure. So the points for today: addiction, upstream, early childhood and adolescent prevention, develops through a range of family, school, peer, and neighborhood influences. They span from prenatal period to late life. To get ahead of the curve, not just overdose prevention, but to get ahead of the curve and prevent addiction in the first place, then we have to focus on upstream prevention. Most of what is currently being implemented in America as prevention either doesn't work or has not been tested. Registries of what work exist and should be used. And as Dave Hawkins said in that video, these preventive interventions are cost effective. If you can prevent someone from getting involved in drugs and crime, then you have reduced arrest, adjudication, incarceration, and treatment costs, and improved academic completion and improved occupational functioning. People who have done cost-benefit analyses of prevention programs show that they pay for themselves from 5 to life skills training, not life skills pays for itself 10 times over. Nurse-family partnership has a 30-fold return on each dollar invested. So prevention is cost-effective as well as the right thing to do humanly. Community mobilization strategies like CTC exist and to help communities through this process. And collectively and collaboratively, we can improve the lives of people in our communities. That's my consistent message. By working together, we can prevent addiction from happening in the first place. And that's it.
Thank you, Dr. Hill. Dr. Buckley is here joining us as well. She's the principal investigator for Blueprints Healthy Youth Development. And we had quite a few questions come in, Dr. Buckley. So I wanted to start with a couple that came in around DARE and the DARE program. Dr. Hill mentioned the DARE program in his slides, and there are 2 versions, right? And I'm curious, can you explain from a Blueprints lens, those 2 versions were submitted separately, and how do you think through that process and appraisal of the programs?
Well, welcome to all of you, and thank you for joining us in this session. I can talk to you about the process in terms of what we're looking for in terms of vetting the science. I can tell you less detail about the difference between the 2 interventions. Other than DARE is so well known, it is not listed on our registry. And what we look for are, the first thing we look at is whatever that intervention is, what those specific activities are, what that theoretical mechanism is to produce the intended risk and protective factors that they're targeting, and then ultimate outcomes. So we're really looking at a description of those activities. And then we bring it through another level of scrutiny where we're looking at studies that have been conducted and how well those studies were implemented, and studies that meet the evidence standards that we have on the Blueprints registry, meaning that we can trust those findings in terms of effect, We then put it through another round of review where we're looking at what does it look like to implement that particular intervention with fidelity in communities. Who do I contact? What does it cost? What does it take to implement this in my community? And that's our vetting process. To meet all of our, you have to meet all those standards to be on the Blueprints registry. And the DARE program, having gone through that whole process, it's not listed because it didn't meet our standards, particularly around the looking at the scientific studies that have been conducted on the interventions.
Okay, thank you for that, Dr. Buckley. Another question that's come in was around the OLIVE model that Dr. Hill presented. And the question is this, and it's a really great one, right? Given that most of what we do, we don't know if it works or not, according to the OLIVE, right?
Mm-hmm.
What happens when we then require the use of evidence-based programs and policies? So where is that wiggle room for more of the emerging or promising practices? And how can we think through that when either mandated or strongly encouraged to use evidence-based programming?
Yeah, that's a really fair question, a great question. And I would encourage people to think about evidence, like many things, as a continuum. And there's a building process that you go through in building evidence for a particular intervention. So what we encourage is to look at the need of your community. And as you do your research, figure out what is the best available evidence. So step one might be to look to a registry like Blueprints and do a search to see if the particular outcomes or risk and protective factors that you're looking at targeting, if there are interventions that meet our criteria and that then target effectively those risk and protective factors and outcomes. And if you're not finding anything, you might find something similar, but even if that doesn't meet your need, then you can look to see where it is on that evidence continuum. And randomized control trial, which is the design we use on our studies that we look at, it's not appropriate for all settings and all circumstances. So it's really looking to see how far along on that evidence continuum is that particular strategy, and then looking to see if there's anything better that's farther along the evidence. And if not, it is really important to just be aware of what is known in terms of the effectiveness for that particular strategy based on limitations of the research that exists.
Yeah, awareness is so important, right? Knowledge is power, and just putting that into the whole context of the bigger picture is important. How often is Blueprints updated?
We have staff full-time that are devoted to scanning the literature and that follow news feeds and collaborate with other registries to see the evidence they're looking at. And that's an ongoing everyday process. And then we are constantly updating the registry. We not only do we look for studies ourselves, but we have a place on the registry you can go to called Nominate an intervention. If you yourself have a study that you're interested in, you're wanting to know if it meets our standards, you can send it to us. We'll look at it. And on the registry, it gives you a step-by-step process for how to go about doing that and how long it will take for us to review that evidence. So it's an ongoing process. It's an active process. In terms of bringing new programs onto the registry, it does take time to review the evidence and put it through our whole vetting process. And then we don't just look at new programs. We're also looking at existing interventions on our registry and constantly looking at the literature to see if there are any updated studies, to see if that intervention perhaps has been tested in other communities, and constantly updating the evidence. And we list on the registry every study that we've looked at, when we identify what the strengths are and the limitations to each study within each program that we evaluate.
Thank you. And I think we have time for one last question, and that is, if someone has a program out there operating that they would like to have appraised by Blueprints, talk them through that.
Right. So I mentioned that briefly in my last response. I would encourage you can Google Blueprints. We also, our link is in the toolkit that's being disseminated through this summit. And you can go to our registry And there is a tab at the top of the registry, right on the homepage, that says Nominate an Intervention. You click on that and it walks you through the process. So what we're looking for is you have to have a study that's been conducted. So some kind of report that's written. It doesn't have to be an academic paper. It could be any kind of report that's been written. And in that study, it needs to describe what that intervention is. So what those activities are, what the risk and protective factors are potentially that are being targeted, and those outcomes. And then it has to have what we call a treatment group and a control group. And by that, I mean a sample or people within your sample that received the program, and then they're being compared to people within a sample that did not receive the program. And you're looking at differences after data have been collected and the study is completed. So if you have a report, we have a website, or we have an email address, you can send it to us, blueprints@colorado.edu. Again, it's listed on our website. You email it to us, and then we give you the timeline it will take to have us review it and vet it. And then after we've gone through the review process, we'll give you feedback. We'll say, here's, meets our standards, and here's what it looks like now in our registry. Or if it doesn't, we'll say, here are the things that concern us about what we found as we looked within the study.
Thank you, Dr. Buckley.
Mhm.
And just for all of you to know, we are offering a post-summit support webinar on using blueprints, how to navigate that when you are searching for your own evidence-based strategies to implement in your communities. So we will be offering a full hour and a half dedicated to this process. Another question that came in was related to other clearinghouses, and there are other registries out there, and all of those are listed on our Prevention Intervention Resource Center. That is on the ADAPT webpage. You all have a link to that in your resource supplement. All right, with that, we are going to conclude for lunch. We will welcome you back here at 1:15 to learn a little bit about social norms and that particular approach to substance use prevention. And the evaluation links, because people are still having some problems, we are posting all of those in the chat. So don't worry, you'll have access to those. And we'll see you back here shortly. Go enjoy some lunch.